You're listening to Medscape's In Discussion series on lung cancer, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Jacob Sands, instructor of medicine at Harvard Medical School and physician at the Thoracic Oncology Program at the Dana-Farber Cancer Institute in Boston, Massachusetts. Relevant disclosures can be found with the episode show notes on medscape.com. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Jacob Sands, thoracic medical oncologist at Dana-Farber Cancer Institute. Welcome to Medscape's In Discussion series on lung cancer. Today we'll be discussing immunotherapy and lung cancer treatment. But first, let me introduce my guest, Dr. Jared Weiss. Dr. Weiss is a professor of medicine at UNC's Lineberger Comprehensive Cancer Center, where he runs a joint lung and head and neck cancer section. Dr. Weiss, welcome to In Discussion.
Thanks for having me.
So before we start really diving into the topic of immunotherapy and lung cancer, I want to start out with your career path. What was it that led to this point for you? For many, it's different journeys, and I'm interested in some of the details of yours.
Well, if you had asked me in medical school what I thought my career would be, at least in first year, I would have said private practice neurology, probably somewhere in suburban New Jersey, and that's obviously not at all what happened. I made most of my decisions in life very analytically. I've made very few decisions intuitively, and they've been the most important ones I've ever made. The first was to become a cancer doc. My plans to become a neurologist, probably a pediatric neurologist, were derailed with the first cancer patients that I met in medical school. They felt like my people who I wanted to serve. And then it took a further twist. I then thought I was going to be a melanoma doc, and that came out of an interest in immunotherapy. As you know, when I was in training, that was the only cancer, maybe renal, that immunotherapy was really a thing for in solid tumors. But the twist came when I met my first lung and head and neck cancer patients in fellowship. And again, very intuitively changed my mind. These were heavily stigmatized cancers, but it felt like someone needed to care about these people. And so I was very intuitively drawn to wanting to serve them. But then at that point, I had this disconnect between my scientific interests and my human clinical passions. And that led me to be an efficacy-based clinical trialist for the first years of my career until happily PD-1 became a thing in solid tumors, thus our conversation today. And I became immediately involved in those efforts from phase 1 through phase 3. And then in most recent years have been inspired by collaborators in the development of the science to focus on what I might loosely call personalized immunotherapy, the idea of making an individual product for each patient, be it a vaccine, a TCR, CAR T, TIL, or such.
So it has been amazing what has happened in the last decade in lung cancer treatment, and a significant portion of that really has been targeted therapies, which I think we need to get into a little bit before we discuss things. And then, of course, immunotherapies. And really in the last 6 to 7 years, we've now seen checkpoint inhibitors initially in the second line setting and really now well established in the first line setting. Before we dive into the first line treatment, can you just discuss a little bit about the importance of genomic testing prior to decision-making in the first line setting? Maybe some of the specifics around that genomic testing. Do you do PCR? Do you do targeted? Do you do NGS? Give us a bit of what needs to happen before we start looking at first-line treatment and immunotherapy considerations.
So if we now have 3 basic classes of therapeutics: targeted therapy, immunotherapy, and chemotherapy. Targeted therapy in most cases is our preferred option. There are details and nuance to this, but they tend to be the least toxic. They tend to have the highest response rates. They tend to have the greatest durability, and they demedicalize the life of the patient. So genomic testing is absolutely critical before initiating frontline. And the first reason is because of how wonderful targeted therapy is. But it actually goes further than that. So number 2 is that multiple of our genomic markers are not only positive predictors for targeted therapy efficacy, but powerful negative predictors against immunotherapy efficacy, particularly in EGFR, ALK, and RET, but the data is evolving on other targets as well. And then the final reason why it's so critical is that in many cases, TKI is more toxic if given right after immune therapy. So for all of these reasons, it's absolutely critical that the first step in decision-making be molecular, even though the result for that comes back after the PD-L1. I'm also very passionate about the kinds of testing. In CME, folks like you and me and the guidelines love to say broad and sensitive testing. And that's fine, but I think it leaves a little to be desired for those who don't think about lung cancer nonstop all day as you and I do. I think that what really the standard needs to be a DNA next generation panel with an RNA fusion panel to have both optimal sensitivity and specificity. And there are multiple commercial vendors that offer that. Those are the characteristics I think that one needs to make sure the panel has.
To specifically round that out, you made mention, for example, of targeted therapies like osimertinib, which we've seen in combination with checkpoint inhibitors, PD-1, PD-L1 inhibitors, that combination really leads to a surprisingly high rate of pneumonitis. And these checkpoint inhibitors with the long half-life, if they start on this and then later switch over, they're essentially getting that dual therapy and has high risk. So I absolutely agree. I start with this point because I just think it's so important. And to add to that, when I see patients and we're needing to do genomic testing, we're still doing the workup and they're having symptoms and we really need to start treatment urgently, then I will do chemo alone as we finish out that genomic testing. So this whole discussion we're going to have about immunotherapy is very exciting. It is a new era. This is really altered outcomes, but it really needs to be coached within the context of that genomic testing having been done. There are nuances to the genomic testing, and so there are some genomic alterations that show up where immunotherapy is still something we'd expect to have a benefit from. So this is not just broadly all genomics or no genomics, but rather get genomics and look at the specifics of that. And then for those appropriate, now we're going to move forward with the discussion about immunotherapy, which has been truly revolutionary. So about 6 or 7 years ago, we started with checkpoint inhibitors in the second line setting, and this has now really moved very squarely into first line setting. To start with, why don't we start with Pembro as a single agent, going from Keynote 024, which was the PD-L1 greater than 50%, and then also Keynote 042, which is just PD-L1 of any expression. Can you go over those two studies in general and really your thoughts around single agent Pembro to start with?
Yeah, so those were the two studies that got Pembro approved for the PD-L1 positive population. To my mind, the who is the most important question here. The FDA approval for pembrolizumab as a consequence of Keynote 42 is for any PD-L1 positive patient. But that comes as a result of a predefined and agreed upon statistical analysis plan that I like to call Russian nested doll analysis, where you have the at least 50% enriched population, but then instead of looking at 1 to 49 discretely, you look at 1 to 100, right? And if you take apart these Russian nested dolls and you look at Keynote 42, it's absolutely clear that in the 50 plus population, and I want to put a pin in the heterogeneity there and come back to it in a minute, but at least in the 50 plus population, that Pembro is clearly superior for survival to platinum-based doublet therapy. It's less clear that that's true in the 1 to 49% population. The survival there really is fairly similar with monotherapy Pembro to platinum-based doublet therapy. And that might be fine in a world that had only Pembro alone or platinum-based doublet. So as a result of this Russian nested doll type analysis, we have FDA approval in the 1 plus population, but it's not clear that it's appropriate therapy for the 1 to 49s. If you look at those survival curves, Pembro and chemo seem roughly comparable for survival. And that would be fine if we lived in a world that only had Pembro monotherapy or platinum-based doublet therapy. But as I'm sure you'll get to in a few minutes, we live in a world that has platinum-based triplet therapy that is probably superior for those folks. So what 42 told me, together with 24, was that for PD-L1 50 plus, it is better to give Pembro monotherapy than platinum-based chemotherapy. It left unanswered the question of triplet versus Pembro. And what really was left unanswered is whether 50 to 99 are all homogeneous in terms of benefit over platinum doublet, or whether we really need to torture the data further into confessing a difference between the different levels of high expression. We had data that came out subsequently. I think the best data set was with cemiplimab, showing that the very highs may be driving most of that benefit. And then an FDA analysis that I'm a little more circumspect about at ASCO that further strengthened that point. And so what I do in clinical practice with this sort of not totally clear data in the 50 to 100 population is I ask, how scared am I of progression in those that are high but not very high? So in say my like 50 to 89 kind of population, if I'm scared if I have bulky central disease starting to compress an airway, becoming symptomatic, growing rapidly, and if I have a certain level of fear element, and this is a little bit the art of medicine here more than definable characteristics, that's where I'll give the patient triplet, even though they have a PD-L1 that is at least 50%. The reverse can be said, by the way. In the 1 to 49s, if I have a patient with an unusually low fear factor for what progression is going to mean, say that patient who has a bunch of dots in their lungs, in both lungs, proving metastatic disease, perhaps by a wedge biopsy, but really very, very, very low bulk disease, I don't think it's wrong to consider pembro monotherapy alone in that patient. Now, there's a high chance that your first scan will show progressive disease, but it's also very likely that that patient, that's going to be a radiologic event, not a human event.
Yeah, that's a lot of ground to cover. And so maybe I'll just, mix in Keynote 189 and Keynote 407 being the chemo plus pembro studies for non-squamous and squamous respectively, and share a lot of what you're describing. In the greater than 50%, I think there's sufficient evidence for benefit to single agent pembro and a high enough likelihood that in that population, that is, I think, a very reasonable first line treatment and probably the preferred in my mind. So just focusing on pembro in particular, greater than 50% pembro. And I also agree in the less than 50%, there's enough from that study to say, okay, pembro is a reasonable option if you have particular concerns about chemotherapy in select populations. But clearly, although approved with any PD-L1 expression, I don't really have a lot of enthusiasm about pembro alone if patients can tolerate chemotherapy. I also want to highlight your point. I mean, if patients have a greater than 50% PD-L1 expression, but they're having symptoms and you want more response, I also think it's reasonable to add in the chemotherapy, and I've done that in that population as well. And I think that essentially what you're describing and what I'm saying I agree with is not necessarily being beholden to one specific rigid regimen in any scenario, but rather recognizing the specifics of that patient's situation and the situation of the cancer, and that you have the option of either chemo plus pembro or pembro alone, depending on some of the specifics, but more broadly, greater than 50% pembro alone, less than 50% chemo plus pembro. Is that kind of a fair summary of maybe underlining what you've already stated?
Absolutely. What we have right now are non-comparative data sets. So what we're doing here is cross-trial comparison. And that's where the art of medicine comes in cross-trial comparisons to try to put together patient values, patient physical status, and the data to adjudicate a decision for each patient. I strongly agree that until we have head-to-head data on each of these questions in narrow situations, it's the art of medicine, not a defined board testable answer.
It's exactly what we're doing with every individual that we're treating, is having to look at different studies and essentially do cross-trial comparison, not only broadly, but actually for that individual in front of us. So it's even more complicated and difficult.
Yeah, I mean, you can have equipoise on a podcast. You can't have equipoise in an exam room, right? You certainly can talk about more than one, but at some point with imperfect data, we have to come down on an opinion for an individual patient.
That's right. So from the Empower data, we've seen atezolizumab combination treatment for first-line non-small cell lung cancer. Can you walk us through a bit of that and some of your thoughts about atezolizumab and the atezo regimens?
I think atezo is a fine drug as monotherapy for the high expressors in combination for the lows, very similar to pembro. The major meaning of that data is that it reinforces the basic story about PD axis inhibition. And I think that a clinician who prefers one agent or the other can pretty comfortably use either and see each of the stories as reinforcing each other. The one place that I find atezo to have a unique data set is the quadruplet regimen of carbotaxol Bev atezo. There was subgroup analysis on that trial. They allowed patients with EGFR ALK who had progressed on all available targeted therapy to go on that trial. And there's subgroup analysis. It was mostly EGFR patients with just a few ALK patients in there, but the subgroup analysis suggested that these patients seem to uniquely benefit from immunotherapy with that quadruplet. And so the places that I'm considering that regimen are in my patients with EGFR mutation who've gotten all possible targeted therapy. And I do mean all. I'll leave that out of the scope of our podcast, but I push it hard, I'll say, for this context. And the other place that I find that interesting is frontline for my exon 20 insertion EGFR patients, where some platinum-based regimen is going to be used in frontline anyway. The biology of exon 20 insertion is really very similar to the classical actionable mutations. It's just different in druggability. And so I extrapolate and consider that, in my practice, a preferred frontline regimen for those patients.
Yeah, and to that point, actually, I would love to see more transparent reporting of the subtyping of EGFR mutations included in these trials. Like, was that a bunch of sensitizing mutations, EGFR mutations? That's a different kind of a scenario. It's great to hear you specify some of that, because I think I've seen people more broadly speaking to EGFR mutations as if it's sensitizing mutations in that study that were enrolled. And so I encourage anyone running these trials and reporting data to really be very clear about some of the subtyping of EGFR within these patient populations, recognizing that those really are different scenarios. Although we're discussing immunotherapy, you did mention bevacizumab, and to me, this is a standout part of this regimen. And so I think we need to discuss that. Is bevacizumab something that you utilize? Is it something you want to utilize? Does that factor into your decision on this atezolizumab regimen?
It's not an agent that I have particular passion for using or not using in the generic sense. There is some historic data that EGFR mutants may benefit more from the addition of Bev to cytotoxic regimens than other patients. So I certainly don't mind it in these populations. In the context of Empower, though, the modern data, you really do seem to need the Bev. If you gave just carbotaxol atezo, those patients didn't seem to benefit from the addition of the immunotherapy. I don't know what hand waving is true. I'm not even positive that clinical signal really is true. But to the best available shaky data I have, I do think you really do need the Bev for now to get that benefit. And so, when you get to subgroup analyses in this way and you dice the data thinner and thinner, we all demand these analyses and then we criticize how poorly powered they are. At some point, you just have to keep it simple as a clinician and do the thing that the trial is suggesting until you have better data. And so that's what I'm doing. I'm restricting to quadruplet.
So that leads us to the next topic of discussion being nivolumab, Nivo-IPI. We have Checkmate 227 of Nivo plus IPI, as well as Checkmate 9LA being Nivo-IPI plus 2 cycles of chemotherapy being the caveat. The idea being now you get fewer cycles of chemotherapy as opposed to the 4, now 2. So broadly speaking, what are your thoughts on Nivo-IPI and how does that add to your armamentarium and your treatment options?
So based on predefined and agreed statistical plan, Ipi-Nivo is approved in the PD-L1 positive population, and 2 cycles of chemo with Ipi-Nivo are approved regardless of PD-L1. And I want to disclose rather directly that I'm about to speak about off-label use that has nothing to do with the FDA approval. So, these were the late entrants to the market. By the time these regimens were approved, we already had Pembro monotherapy for the PD-L1 highs and triplet for everyone else. And so the question isn't only, did these beat platinum-based chemo? They did. The question is also, as a clinician consumer, I ask the question as well, where does this new regimen look better than what I already have? Where am I tempted to change my practice? Because of course, I'm not alone. Doctors are creatures of habit. And the place where I see a most clear answer here are the PD-L1 negative squames, where either of these regimens seem to me in the omnipresent but forbidden cross-trial comparison superior to what I already have. In comparing Ipi-Nivo to Ipi-Nivo chemo, beyond the difference in approval, I think it's important to reflect on what the chemo is buying us. The idea here in adding the 2 cycles of chemo is to protect the left side of the curve. With every immunotherapy curve, there's a lot of progression at first scan. And the idea was that the 2 cycles of chemo would protect patients from that while waiting for the immunotherapy to kick in. I'm relatively unimpressed by the difference in the left side of the curve for PFS here relative to the added toxicity from 2 cycles of chemo. And so to me, 9LA is a niche regimen. I've used it exactly once since approval. In my practice, I consider off-label Ipi-Nivo for the PD-L1 negative squam.
So now to fully round this out, of course, we now have cemiplimab. What are your thoughts on the cemiplimab data? You've referenced that earlier in the discussion, particularly around the PD-L1 expression. But generally from the data that you see in the study, what are your thoughts on use of cemiplimab and of the data itself?
I think it's great data. To me, it's very confirmatory of the data from pembrolizumab and atezolizumab. And what I think it really adds to our literature is the idea that not all PD-L1 highs are the same, that it is different having a PD-L1 of 50 or a PD-L1 of 90. So I think cemiplimab is a fine drug. I have very little passion, though, between the question of use of cemiplimab or use of pembrolizumab for a particular patient.
So what are your thoughts on TMB? Is there a place for it? Are super high TMBs worth considering? If there's a low PD-L1 expression but a high TMB, does that impact your expectations in any way?
My take on TMB as currently measured in commercial assays is that it's not quite ready for prime time. There's some data suggesting you can use it when you're on the fence, but I am not doing so in my practice at this time. I'm pretty much ignoring it. I think you have a warmer take on it, right?
Well, I'll say that it's not something that I really am using clinically. It's something that I've felt for a long time that there was just too much confusion around. And frankly, I think the point you're kind of making as well is that different assays have different cutoffs, and really there isn't even a broad acceptance of what represents high TMB or where cutoffs might have clinical utility. We've seen differences in different data sets. But I think that Nivo data I found particularly interesting with a low PD-L1 expression and high TMB. We actually had a poster at ASCO as well looking at broad data sets. So it was broad data, taking Flatiron data and Foundation Medicine data, looking at TMB expression. And with the particularly high TMB cutoffs, it looks like there may be an indicator of higher likelihood of durable responses. And you've touched on this. And I love the way you described the curves as three sections of what we see within these checkpoint inhibitors, that the first part of that is a drop off. And that really represents, as you stated, that these checkpoint inhibitors don't work for everybody. And if they don't work, we see rapid progression because the treatment's not effective. But similarly, you celebrated that right side of the curve that is inspirational in those really durable responses. And I think for immunotherapy, I use a baseball analogy where immunotherapy is like swinging for the fences. If you connect, you can get these amazing durable responses. But for those that don't connect, it can be a strikeout. And so really defining which patients are going to benefit from these drugs become particularly important. I think we all have patients in our clinics now that are like 5 years or longer out from when they started their treatment, and they continue to come in and have good scans. And obviously this is a small number of individuals, broadly speaking, but those are really the most fun to see. And the question then becomes, are there patients actually cured of their incurable diagnosis? I mean, I can't say one way or the other whether they are or not. And the fact that that's a question itself is pretty exciting.
I'm convinced we cure some patients. I have patients from phase 1 who haven't gotten drug for more than 5 years, who are alive, thriving, and without evidence of cancer. Lung cancer is an awful cancer. One of the only nice things that I can say about an awful, aggressive cancer is that if it doesn't come back quickly, that's because there's nothing there to come back. If you're 5 years without drug with non-small cell lung cancer, or for that matter, head and neck cancer, and you're still NED, thriving, alive, you're cured.
I think that's likely true. It'll be good to see when we have 10 years of data, and I do expect that to happen. So it really comes down to then choosing the patients that go on that treatment. But let's do a quick transition. We'll just briefly discuss small cell lung cancer, because by that analogy, that whole swinging for the fences, we do see from the Empower 133 and the Caspian trial, the inclusion of atezolizumab and or durvalumab based upon those two trials is now the standard of care, with an impressive tail to those curves, although the median's really not statistically significantly changed. I say not clinically substantially different, but can you highlight some of what has made oncologists celebrate those outcomes despite the kind of small median changes?
Low expectations. So, small cell is a very frustrating disease. You and I share a passion for these patients and for improving their care. But unfortunately, almost all of our trials in the last decades have been negative, at least for improvement in survival. It's so frustrating. All the time you get these dramatic, even clinically complete responses. You know you're close to a cure, and you also know that it's going to come roaring back. I think that we've been teased by the ability to cure people with small cell for a long time. And the idea that we can achieve durable control, even if in a small number of patients, is very, very exciting. I like to make the analogy here to pizza. I love pizza. If I'm hungry and you give me a slice of pizza, I'm actually hungrier for the second slice after I'm done with the first slice, not less hungry. That's what immunotherapy in small cell has done for me. It showed me what's possible, but now I'm hungry for a few more slices. I think we all want to cure more people.
Yeah, and I do have some patients that are now years out from first-line treatment, particularly the ones that had enrolled in the clinical trials. So they now have really more years out, in some cases off therapy, ongoing with disease control, with what I like to call high five visits, where they come in, their scans look good, and I say, great, see you next time. And to that point, there are now different trials that are adding drugs to some of these in the first line setting, as well as later lines now with some bispecific, trispecific T-cell engagers. So what are your thoughts on some of what we're seeing down the line that might be that next slice of pizza, as you described it?
Yeah, if you'll allow me yet one more analogy, I sometimes think about immunotherapy as a dramatic immune response as a bonfire. And I think about our existing PD-1 and PD-L1 agents like gasoline that amplify an existing fire. The problem is if you pour gasoline on an unlit log, all you have is a wet, smelly log. And so I find it very exciting, a new crop of approaches that try to light that fire. You mentioned tarlatamab. I find this to be a really, really exciting agent. It's a personalized immunotherapy. It's going after a neoantigen that's particularly common in small cell. Unlike some of the more unwieldy approaches that I spend my time on, it's off the shelf. And we have real clinical data behind it. That bispecific, in addition to the late line studies you mentioned, is also being studied in frontline. And I'm very excited about that. My institution has voted with our feet to try to open that trial.
And with that, Dr. Weiss, wonderful having you on. You always describe things so well, and I really like these analogies. I'm going to bring them forward with me into practice. So to summarize our discussion with immunotherapy in non-small cell lung cancer, we started out really highlighting the importance of doing genomic testing and had a bit of a discussion about what that genomic testing should look like. And then all discussion after really is relevant, particularly in the population that should not start with initial targeted therapy. And so going forward, we discussed PD-L1 expression and how that impacts first-line decision-making with Keynote-024 and Keynote-042, showing pembrolizumab as monotherapy was particularly beneficial in those with a greater than 50% PD-L1 expression. We both expressed a preference for combination chemo plus pembro based upon Keynote-189 and Keynote-407 in non-squamous and squamous cell non-small cell lung cancer, respectively. We also discussed the regimens with atezolizumab from the EMPOWER studies, which also included bevacizumab. We then went on to the discussion of Nivo-IPI based upon Checkmate 227 and Checkmate 9LA, both of which are FDA-approved options. I mentioned, particularly in these studies looking at the low PD-L1 expression and the high TMB, which I found particularly some of the most interesting data from those studies, which led into some of the biomarker discussion that I'll summarize in a moment. And then, of course, we discussed cemiplimab, which is also now an approved option for first-line non-small cell lung cancer. And this is a study that really highlighted the increasing PD-L1 expression as something that indicated a higher likelihood of response to cemiplimab. And of course, there are some other data sets that have showed higher PD-L1 expression leading to a higher likelihood of responses, showing that PD-L1 really is a spectrum in itself. I think we both agree that TMB is not really something that we'd use in clinical practice at this time. I did mention that I do find it really a compelling area of further study, and it may be that higher TMB cutoffs could be an indicator for higher likelihood of durable responses, which is really the home run in the analogy that I used. We then discussed briefly small cell lung cancer, and in the first line setting, the use of atezolizumab with chemotherapy or durvalumab with chemotherapy is now FDA approved, and I think we both consider the standard of care in the first line, with a portion of patients really having durable responses in this very difficult to treat diagnosis. And that led into a discussion of later lines of therapy and some of the studies, particularly in small cell lung cancer, highlighting tarlatamab or AMG 757 as a drug that has really showed some compelling results. And with that, that wraps up our discussion. I thank you so much for tuning in. This is Dr. Jacob Sands for In Discussion.
Thanks for listening to Medscape's In Discussion Lung Cancer podcast series with our host, Dr. Jacob Sands. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com for show notes, links, and more information on lung cancer.